We will now continue on with our agenda. And the next item up is the healthcare competition. Mr. Mose?
Great. And do we have Dr. Daphne on?
I am here.
Excellent. Okay. Members, Don Moulds, Chief Health Director. Pleasure to be with you today. I'm going to talk about a critical topic, which is healthcare competition. With me today is Limor Daphne, Bruce Rauner, Professor of Business Administration at Harvard University. She's a leading expert on competition in U.S. healthcare markets and also will be the lead author on a study she's working on for us at the moment on increasing competition among CalPERS insurers. The game plan this morning is as follows. I'm going to take a few minutes to outline the strategy to address provider competition that I had originally intended to bring to you back in March. The discussion was supposed to happen at the board meeting. We ended up canceling when the COVID pandemic began taking root in California. After that, Limor is going to talk with you about the insurer study that represents the other part of our competition strategy. Both of us are going to be around for questions, though you get more than enough time with me, so my recommendation is that you focus more of your questions on Dr. Daphne and her presentation. Next slide, please. So the general goal of the competition strategy is to use competition to drive down the prices we pay to secure healthcare services and ultimately that our employers and members pay in premiums. If you'll recall from the presentation now, Brennan from the Healthcare Cost Institute gave back in January, it's the price of healthcare, not utilization, that's driving the increase in healthcare costs. That price varies dramatically when you move from one part of the country to another. Within California, there is also tremendous price variation. As a general rule, there's an inverse relation between the price of healthcare and the prevalence of competition. So the higher the prices, the less robust the competition. This is almost universally true on the provider side. As Limor will explain in just a minute, it's more complicated on the insurer side, where both too few and too many insurers competing with one another in an area can be detrimental. In general, sufficient competition is a struggle in lower density, geographically isolated parts of the state. This is true on both the provider and the insurer side. And one of the things that people tend to forget about California is that even though it's home to several very dense urban counties, 42 of its 58 counties have less than 500,000 people. Not so geographically little Alpine County in the upper northeast of the state has a population of 1,129 people. But on the provider side, high prices caused by the lack of competition isn't just an issue for rural California. There are plenty of urban areas of the state that now suffer from the same predicament. Why? Because over the last decade, there's been significant consolidation in many parts of the state. This happens in two ways. It takes place through horizontal mergers, where one hospital or medical group purchases another. It also happens through vertical consolidation, which is most typically when a hospital buys a physician group. With vertical consolidation, hospitals sometimes use referrals to drive up costs, and they can also use other gimmicks like adding a hospital facility charge to a service because the physician providing that service is now affiliated with a hospital. The incidence of hospitals buying physician practices has increased over 75% since 2010, and it's been linked to significantly higher prices. A study that took place in 2016 attributed a 12% increase in premiums due to vertical consolidation alone. Next slide, please. This is our provider heat map using the end of 2018 data. The blue areas are where costs are lowest, and the red areas are where costs are highest. A little bit confusing because the darker the red, the higher the cost, and the lighter the blue, the lower the cost. But you should get the idea. In Southern California, there's a great deal of competition and generally lower prices. In the north, there tends to be less competition and higher prices. The spread between the light blue and dark red parts of the state is more than 40%. You'll notice that many of the red areas are also decidedly urban. San Francisco and the whole East and South Bay area are dark red. And Sacramento, once a low-cost area for healthcare, is also now in the red. The practical consequence of this variation is that price for the same procedure can vary dramatically depending on where it's done. Recent research by Richard Scheffler at UC Berkeley notes that the cost of a childbirth without complications is twice as much in Monterey as in San Diego, and a colonoscopy in Sacramento is 55% more expensive than the same procedure in Orange County. I should note that we've been working with Milliman to update the heat map, and they just recently shared a draft with us. So I'll plan on sharing it with you as soon as it's finalized. One of the interesting new features we're adding this year is the ability to break out costs according to settings. So this year we're going to be able to see variation by hospital and outpatient costs. This will be helpful for our provider competition study, or strategy rather. Some counties are uniformly high cost. In others, like Santa Barbara, hospital costs are high, but outpatient costs are comparatively low. In those places, networks that use contracts to derive services outside of a hospital setting where appropriate are likely to be particularly impactful. Next slide, please. We're going to be returning to the issue of provider competition often in the next few years. As I mentioned, there are a number of different ways that lack of provider competition causes prices to increase, and we're going to need different levers for addressing them. Our focus in the near term is going to be on areas of the state where there is limited or no hospital competition. More than half of CalPERS health dollars go to hospital-associated care, and we see some of the most significant price variation in services that are provided by hospitals. Both Santa Barbara and Monterey are counties with only one hospital, which is why we've been doing the work with Blue Shield on lower cost solutions in those two places in particular. Next slide, please. In order to control costs in areas lacking sufficient provider competition, we plan on conducting various research activities. These include understanding the cost drivers in a region at a granular level by procedures or episodes of care in particular. Using this information, CalPERS can develop profiles and benchmarks of providers based on a market basket of healthcare to know how they compare. This information can help CalPERS and its insurers contain costs. Various other strategies have been developed to address the lack of competition among providers in a geographic area. CalPERS is actively considering several of them, and in a few places we've started to engage our insurers. We've gotten a preview during the discussions of our work with Blue Shield. The strategies that we see as particularly promising include working with insurers to develop networks that compete for services that can be done outside of the hospital. Moving services outside of a hospital setting reduces utilization at high-cost facilities. This includes increasing the use of urgent care, clinics, ambulatory surgery centers, and non-hospital-based imaging centers where appropriate. This is the strategy we've been working with Shield on in Santa Barbara, and we're also trying to employ in Monterey. Next, better and more frequent use of telemedicine. When there are few providers in an area, telemedicine can offer more options for our members and more competition for services. Evidence suggests that it's particularly effective in helping address the lack of mental health services in rural areas where there aren't always enough providers. But this can also improve choices and increase competition for other services. As I think all of you know, and some of you have probably experienced personally recently, the COVID pandemic has pushed a lot of care into the realm of telemedicine. We're currently developing an evaluation of our own members' experience with telemedicine during COVID, and are in discussions with Covered California and the Department of Healthcare Services. We've had a a couple of meetings among leadership of those other organizations about whether we might be able to collaborate on a project that would look at the experience of telemedicine across all three purchasers. Next, using our specific claims experience to work with our plans to tailor our networks to the highest value providers, those that offer high quality care at an affordable price, and using the same data to more directly engage in provider negotiations, using our purchasing power to influence pricing where possible. And last, identifying hospitals outside of high-cost areas where members would have the option of going to receive high-quality care for specific, highly specialized services. Lowe's and McKesson have implemented a version of this strategy for services such as heart, hip, and spine surgeries, where their employers travel to a single or a few regional hospitals. Other large employers have given their employees the choice of flying to places like Mayo or the Cleveland Clinic, where they receive world-renowned care, and the price point, even including travel costs, is lower than at a local hospital. Some of these strategies have been adopted by some of the labor union trust funds as well. Even in geographic markets with adequate competition, provider consolidation remains a threat to reducing competition. Our other strategies to address provider consolidation include using legal avenues such as partnering in lawsuits, challenging anti-competitive mergers, and serving as experts in the review of mergers. Another strategy is to increase our legislative engagement. I'm going to turn it over to Dr. Daphne now, but before I do, I want to remind you that there are two reasons for focusing on competition. One is lowering the price we pay for healthcare, but the other is that in areas where there's robust competition,
Don, you there? Like we lost Don, can you hear me?
Don shows us muted on my screen.
Yeah. Don, are you? Okay, well, I'm going to ask Mr. Rubalcaba, do you have a question for Don, or do you want to wait till Dr. Daphne completes?
I will wait. Thank you, Mr. Jones. I will wait. Appreciate it.
Okay.
Thank you.
Okay, but we do have a question for Don, Miss Wesley.
Yeah, I just have a quick question about the telemedicine and talking to folks about including those options. Under what circumstances would telemedicine be preferred versus an in-person patient visit? Have you gotten that deep in the weeds yet?
Sorry, we haven't done the, so part of the idea behind the evaluation and engagement to find out more about our member experiences, to answer questions like that, there has been research that's been done on this, and there certainly have been surveys that have been done outside of CalPERS, which suggest that, there are a bunch of different reasons why, in some instances, people prefer telemedicine. One is that if you live in a really rural area and you have to drive 100 miles to see somebody, which would be problematic from our network requirements, obviously, but theoretically, telemedicine can be more efficient. Professionals who are used to, especially younger professionals who are used to doing more on a screen, sometimes like being able to fit a consult in between two meetings rather than driving to a doctor's office. There's some research done on mental health services in particular that show that for some people, there's a stigma attached with going and sitting in the waiting room, and they just like the anonymity of telemedicine better. So there are reasons like that. And the other, obviously it works better in some areas than others. It is easier for certain types of consults, and certain things are just not possible. I hurt my ankle because I was running outside and not on a treadmill over the last few months, and going to see an orthopedist not super helpful via telemedicine. So didn't even bother. But that's part of the purpose of taking the deep dive. We've got so much experience right now that we didn't have before, using telemedicine for all sorts of things that we didn't use it for before, that we think it's an important time to really dive in and get a better sense of where it works and where it doesn't work.
And I appreciate that. And I think it'll be interesting to see what you guys bring back. I mean, my only concern, of course, would be having patients. We need to deliver care that's quality and also deliver it cost effectively for our membership, but making sure that we don't push too much into telemedicine for cost effectiveness if it's putting some patients in a place of the doctor, but instead being forced into telemedicine. And I could see that perhaps some corporations would want to do that for their own purposes. So just a flag, and I'm looking forward to hearing more about it.
Yeah, absolutely, and that's obviously front and center for us too. And part of understanding it, that one, we envision it as a choice rather than a forced option, and two, it's going to be critical that we know that the services being provided are doing what they need to do. So yeah.
Okay, well, thank you, Don. You want to introduce Dr. Definite to move forward?
I did a little bit, but I will again. So Lemore, thank you for joining us, and I'll turn it over to you.
Okay, terrific. Let me just confirm and ask if you could nod at me if you can hear me properly. Okay, we will do. Oh, a thumbs up, even better. So I am very pleased to be here today to a competition study commissioned by CalPERS, which I'll be leading. Next slide, please. Next one. Okay, so what I wanted to start with is some background as to how the study came about. Dr. Moulds approached me last fall. He inquired about my interest in capacity in conducting a study to inform CalPERS' thinking about its health insurance offerings. He explained it had been some time since CalPERS had last undertaken kind of a 20,000-foot assessment of plan structure and design and the vision for the agency, the organization, with respect to its insurance plan offerings, and that he was eager, CalPERS was eager to tap some academic insights into developing that vision. Now, as Don had mentioned in his presentation, my research focuses on provider and insurer competition. I've been thinking about these topics in a range of U.S. Healthcare subsectors for, I'm sorry to admit it, more than 20 years. Speaking of that, by the way, Don, I can tell you what to do about that running injury. It's pretty age-related. Anyway, so in addition to being an academic who focuses on these things, I've spent time as a deputy in the Bureau of Economics at the Federal Trade Commission, looking at antitrust issues, anti-competitive practices, as well as potentially anti-competitive mergers. And I've worked with a variety of other organizations, not-for-profit and private, trying to understand how our markets are working, or more commonly, how they aren't working, and what could be potentially done to improve the current state of the world. And I'll just note that I logged in a little bit earlier, kind of to test the connection, and I had the opportunity to hear a few members raising the financial difficulties associated with extraordinary healthcare costs. And that is truly the motivator for all of this research and this work, which is really, can we use market forces together with active, engaged purchasers to deliver higher value to enrollees who are suffering tremendously because of what's happened to private sector healthcare prices in the US. So we're very, very motivated by this intellectually, but also want to engage in working with together with employers to do something about it. So this was a great opportunity that Don asked me about. And in thinking of it further, I asked for some support from an economics consultancy because in order to execute this sort of work, as I'll describe in a moment, it's going to require a fair amount of data and analysis. The consultancy that I like to work with is called Bates White. You see their name, or yeah, there you go, at the top of this slide. And through Bates White, I was able to add 2 experts to the team. They are, I believe, streaming in, but not panelists today. Both PhDs in economics, Zenon Zabinski, who has done a lot of modeling of this kind, and Professor Robin Lee, who is my colleague at the Harvard Economics Department, and is one of the pioneers of some research on how insurer competition can affect the prices that providers receive, as well as the premiums, of course, that are paid. And his research has used CalPERS data in the past, so it was terrific that he also is an affiliate of Bates White and can be easily engaged in working on this project. So what we did next is we performed a scoping assessment with support from the California Healthcare Foundation, and we submitted it to CalPERS and had a good discussion, iterated around that scope and what would be involved in undertaking a study. And if we go to the next slide, you'll see the goals that we agreed upon for the study. So these are consistent with the motivation that I described when Don initially approached me, essentially trying to assist in figuring out what would happen and to whom if the set of health plans that are currently being offered changes, okay? And to use what we learn from our models and our predictions to, should it be requested, offer recommendations from which CalPERS can select based on their priorities and their objectives. Okay? And I think how these recommendations might come about will become more clear when I describe the type of modeling that we're doing. Last is that our objective is to produce something that is flexible enough so that CalPERS can, with some tweaking, essentially change around proposals, feed it through the model, and sort of see what happens. And one of the changes they might propose to evaluate, I understand, is to think about how changes in the premiums, perhaps that enrollee space, could impact the decisions and the total prices and the value. Okay. Sorry, slide advance, please. Okay, so I assure you there are not too many more slides, but I wanted to provide you with a little more detail so that although this will still feel like a black box, it is a multicolored progression of steps that we plan to undertake that will basically implement a systematic evaluation so that you have evidence-backed, an evidence-backed tool for considering different proposals, right? So the first step is, and that's the step we're currently in. You can imagine it takes some time, and there's a host of course, security and privacy guidelines, but we're trying to gather as much data as possible. And we aim to use that data to build, for starters, a model of the plan choices that members are making. And I'm going to describe that model in a moment. But so one set of data is about the choices that people are making in terms of the insurance plan that they select for their families or for themselves. Right? Another set of data concerns the medical utilization of the members and their dependents. And we need that information partly because we want to assess how plan choice intersects with that utilization. So to give you a hypothetical, it may be the case that an enrollee in a well-managed HMO, even with the same underlying risk characteristics, over time experiences lower healthcare spending, lower utilization than an enrollee in, say, an unmanaged PPO plan. but we would prefer not to rely on an assumption about that difference, but to actually use the data over time to tell us whether that is the case and by how much that is the case. So you understand the purpose of gathering these sorts of data, all of course de-identified and compliant with all guidelines. And another objective of these data is that by seeing the utilization, the encounter data, we ought to be able to estimate what insurers' margins are. And that is going to be pretty informative when it comes to negotiating for premium rates. Okay, so that's the data piece and the reason that we want a data intensive effort, and CalPERS is fully in support of that. Moving on to the stage 1 of the model, right? This model, oops, we're not on this slide. We're on this slide for a while, but we're still just in stage 1 of this model. To estimate plan choice, what we're going to do is take the data, as I mentioned, on enrollees for historically in every area, what set of plans they were offered, what are the characteristics of that choice set. So what are the premiums? Who are the carriers sponsoring the plans? What does the network breadth look like? What is the product type, HMO or PPO? And we're going to use all of that information to build a model that reflects the choices that consumers are making, so that if we changed the set of plans that they have to choose from, we could do a reasonable job predicting which plan they would choose based on their prior choices. So for example, we might find patients with a certain condition, a certain kind of cancer, are likelier to select one kind of plan. And so if we made a change, we would incorporate that preference in predicting what is likely to happen to market shares, okay? Now, my understanding is that in marketing, this is called conjoint analysis, if that rings a bell for anyone, except for we'll be using actual rather than hypothetical choices. But essentially, it's a way for you to predict what would happen if you changed a product or the set of products from which people choose. And that's pretty important because we're going to feed that into stage 2 of the model, which is about predicting what are the premiums for these plans if CalPERS decides to change the set of plans that are offered and the characteristics of those plans in any different geographic area. Okay. Now, on the one hand, in stage 1, we will see the benefit of plan choice because more choice can enable individuals to select a plan that better suits their needs. But of course, there are downsides of more choice. We all know administrative burden associated with a large number of plans. We're also familiar with choice overload and the cognitive requirements associated with having to evaluate too many options. There is also a downside that gets incorporated in this stage of our model, and that is if an insurer has too small a share, too many insurers, it has less bargaining leverage vis-a-vis the providers that might be demanding pretty high prices because it can't swing its membership around if it doesn't have that much membership. And we will consider how a larger insurer may be able to negotiate lower provider prices in this part of the model. We'll try to incorporate that. You may find that having one very strong, or probably not one in addition to Kaiser, but maybe 2 stronger plans, larger plans might be predicted to be more effective in containing premium growth than a set of smaller plans. But of course, it will depend on the marketplace, and it will depend on the characteristics of the plans and the individuals in that market and their preferences. Okay. Stage 3 is where we put it all together, right? And we're going to feed alternative proposals through this model and then spit out what the results are. It's not so mechanized, but we will be able to make predictions on, say, demographics, which enrollees are likely to make changes to their plans. Do we predict that their utility is higher, that they are happier based on this set of new plans that is offered, based on how much they value the reduction in premiums versus potentially loss in provider choice, if that is a trade-off to be made. And we'll also be able to look at the effects on CalPERS outlays. So together, the hope is that we can feed through enough scenarios that we might be able to synthesize some policy insights for CalPERS. What could that be? For example, we could find that a very high value scenario might be to offer a low cost HMO wherever Kaiser has a significant presence. Okay, that's a hypothetical. And if we saw that that was pretty significant, we could identify in which markets it might be. And it's conceivable that the organization might choose to make some kind of a public signal to that effect and say, if we had such a plan that satisfied these criteria, we would be willing to consider some kind of an exclusive, I don't know, exclusive, but like we would offer this particular HMO and only one or two other plans where it entered. You could imagine moving the market to the benefit of your enrollees, depending on the strength of the recommendations. So that's the idea. Obviously, we don't know what we're going to find and whether it will be that systematic or highly varied by geography. It depends on what the data tell us. So let's advance to the next slide, because I think that the first point here is very significant, which is we can imagine a great precision in our projections, but that depends very highly on the limitations of the data that are given to us. And we are still ironing that out. Some of it has to do with confidentiality over what zip code units one can reveal. Some of it has to do with, are we able to get utilization data from Kaiser so that we can estimate what we want to estimate about individuals' health, as well as the margins. So the accuracy of our predictions will, of course, depend on the quality and granularity of the data that we are able to feed into the model. We also are making some simplifying assumptions, both to speed the deliverable of the model and because we don't want to incorporate too much complexity. For example, we're assuming the same negotiation between CalPERS and plans, as opposed to some hypothetical alternative circumstance where, say, CalPERS would announce we're going to take the 3 bids and everybody bid and then you select. That would be a different negotiation process. We're going to assume that the negotiation process continues as it has, and the scope of our project is limited to the commercial plans at this time. So I will stop there, having said quite a lot, and be glad to answer any questions you may have.
Well, thank you very much, Dr. for, excuse me, for the presentation. We do have a question. Mr. Rubalcaba, please.
Thank you, President Jones. Very good presentation. Thank you, Dr. Professor. I'm not sure what the right title is. And I want to commend Don Moles for bringing you and the Bates White team to do this. It seems like quite an undertaking, and I'm glad that CalPERS has a data source to provide you with meaningful information that can come out with your recommendation. Both the previous presentation and your presentation raised a lot of questions and turns like things that I thought I knew, turns them upside down. Like the whole thing about, we've been talking about the whole thing, you have to be the right mix of plans and plan types, and plan types sort of suggest there might be some plan design changes. And the other, I think one of the key points that you both have made is that having more insurers doesn't necessarily lower premiums. And the whole thing is, I can see how that could be true when there's fewer providers, but how does it work but there was a comment made, or one of the slides or the document said that another situation could be when there's low competition among providers. So I'm not sure what will be the situation where there's low competition among providers when there's many providers, because it seems to contradict the whole thing about managed competition, that theory that David Miller mentioned earlier in the session. So that's one question. So I'll wait till you answer that one, then have a couple more.
Do you want to, Limor, do you want to tackle it, or you want me to jump in?
We can just tag team. I think my answer will be brief. First of all, thank you very much for the question and for listening intently. I absolutely concur that CalPERS is used both in its extraordinary data and in its vision and forethought. I have, many academics in the past have documented innovative things CalPERS has done, including the reference pricing initiative and shifting toward high value care. So this is consistent with an employer group that is really thinking hard and aggressively about what to do. So I concur with that. Your question is, it sure seems like you might be talking, you said it more politely than this. Sure seems like you might be talking out of both sides of your mouth here, where insurer competition is a good thing and then insurer competition might be a bad thing. And the answer I'll give you is unsatisfying but true, which is to say that it depends, right? Research that I have myself done looking at past insurer mergers and that was quoted in blocking the Aetna Humana and Anthem Cigna mergers found that when the insurance industry becomes more concentrated on average, that premiums do rise, okay? On the other hand, there is ample evidence that shows when insurers consolidate that payments to providers decline. So if you can ensure that there is some pass-through of that, there's a balancing tension, and that is something that that is going to depend on the specifics of the market and also on the bargaining leverage of the employer, the purchaser in that case. And Donna, if you want to add something.
No, that's great. I'll just add that part of the underlying answer, which is it depends, is why we've engaged Dr. Daphne and her team, because there are more simple rules in some parts of on the provider competition side. Some of them are more complicated, but on the insurer side, it really necessitates a deep dive into a particular area to get at the right answer, and we need a model using our data to make those calculations. That is what is missing. It helps us in our negotiations. It helps us think about when we add a plan in an area and when it might potentially be detrimental to add a plan in an area. So it's really, I think it speaks to the need for this kind of work, the fact that it's a more nuanced answer.
Thank you. I just have a couple more comments here and one question. First, I forgot, I was remiss, Mr. Malta. I also wanted to commend you for being able to bring in the California Healthcare Foundation to help fund the study. So I think that's very good, and it speaks to the interest in this study. And I look forward to recommendations to be done by Dr. Daphne. Dr. Daphne, I noticed in your bio that you also have worked on reverse payment settlements in the pharmaceutical industry. So I know this study is more on medical plans, and I saw somebody share with me an article where New Jersey is starting something called reverse auction. Sorry, New Hampshire, but New Jersey did it before. And so at some other time, when this study is done, maybe we can talk about how to tackle the pharmacy issue.
I'll talk your ear off gladly.
But my last question is, I'm sure your study will come out with some recommendations, but one thing that I always, again, the question about it, the answer is it depends. It's the whole thing about, there was I talked a little bit offline with Mr. Don about this. The consolidation not only of the the hospitals and the insurance companies, but also of medical group practice being bought out by either the hospitals and or the insurance companies, and how sometimes, I guess it depends. I mean, I was taught to believe that can be more efficient, like for example, the staff model, but yet, and somehow these neural networks they can bring quality, but yet the literature seems to say that it's not always the case. So can you expand about it? I know the answer is it depends, but what are the variables that will make it so? And I know some of it, like the whole thing about too many insurances. I always talked about, I guess my concept has always been about not so much the prices, but about the risk pool. Overlapping too many networks, it sort of splits up the risk pool. But now we're talking about prices. So I'm trying to understand these two different theories. One about risk pool, which will be in the later afternoon, but also about the price. So can you speak to that a little bit? And I know it's a little confusing question, but it's a confusing topic for me sometimes. Thank you.
I'm happy to start with that, and just to observe that this time, instead of saying it depends, I'm just going to say you're right. But I do think that both of these observations are consistent. So let me explain how. It is certainly possible that when, say, hospitals have an ownership stake in or acquire physician practices, that there are some efficiencies to be gained. Right? That's what you heard. That's what makes sense. You can maybe share a medical record. You maybe can coordinate to avoid readmission to the hospital. That is the goal, is not to consider these as silos, but for the entire organization to be maximizing the health of the patient. Okay? So there is potential for efficiencies. In practice, we haven't seen evidence of those, I think for two reasons. One is that without competition, there is not much incentive to pass those efficiencies down to consumers, even if they exist. Instead, you might say, wow, wouldn't it be great if we had this new technology, or if we had this expertise, or we invested in this initiative. So without any market imperative to pass your cost savings along, you think of other wonderful things you can do, whether you're a nonprofit or, in the case of a for-profit, returning profits to your shareholders. So that's one, and that's why we need really active purchasers or some way to stimulate competition. The second reason is that oftentimes, even if they're clinically integrated, they may not have the same aligned financial incentive. So whereas a Kaiser, vertically integrated all the way, has an insurer that is, keeping an eye on the total tab, and they might be willing to consciously spend more on, say, drugs and office visits so as to avoid hospitalizations because they see that that hits the bottom line. Just at a hospital and doctors, they themselves may not have a structure in place to jointly be trying to minimize the entire cost of the patient experience. And I will add, maximize the ease with which the patient accesses everything. So to some degree, it's not enough integration, but even if there is enough integration without competition, you may see those integrated providers spending money on things they value, which may not be the same things that consumers would want, which could often be lower prices.
Thank you very much, Dr. Oh, sorry. Go ahead, Mr.
One other piece, if it's okay, just on the question about quality. So you pointed out that some of the consequences of consolidation have been characterized as a good thing. Integration of care, for example, very much a good thing. And a lot of the promise of the Affordable Care Act was that there were incentives to create these accountable care organizations that would be more integrated, and certainly some of the explanation for this kind of consolidation is just that they're trying to come to more integrated systems. As Dr. Daphne points out, the practice has not met the theory in a lot of instances. So this is why it's so important that as we move forward with mergers in California, that they be analyzed on a bunch of different levels. And one of the questions is there going to be added patient value? And is there going to be true integration?
Thank you. One last question, and I'm assuming your study would point to this and your recommendations, the right mix, because we also have high-cost hospitals, which are highly coveted by the networks and the insurance companies because they have a brand reputation and they have their own, shall we say, ad campaigns. So they're very highly valued by the membership. Maybe not so much by the insurance because of the high negotiation tactics. So will there be a place for how to dissect, how to deal with those, and so everybody benefits, like a win-win? How would, any thoughts on that? And then I thank you for your time and thank my colleagues for letting me go on a little bit. Thank you.
Limor, do you have anything to add on this one, or do you want me to take it?
Well, I have two. I do. So one comment is I can't sugarcoat this. Because no one can. Some of these systems have extraordinarily high prices. They're very desirable, and it is difficult to discipline these prices. So we ought not harbor illusions that active purchasing can undo all of that. This is partly why it is so significant that your Attorney General has succeeded in negotiating a settlement with Sutter, right? And I think that's actually going to pave the way for some actions in the rest of the nation. It's later than ideally it would have been, but I'm hopeful that that might be powerful in terms of trying to bring some of the rates down. With respect to our analysis and whether we'd be able to assess the impact of, for example, plans that engage in more tiering or steering, where you're only able to access these providers if you have a higher copay or if you have a particular condition where they've been demonstrated to be higher quality, that sort of thing. I don't think that we'll have the data or the scope to truly analyze that empirically, but I think it's an interesting extension.
Thank you, Mr. Jones. Thank you, everybody.
Okay, thank you. Ms. Brown.
Thank you, Mr. Jones. My question is for Dr. Molds. How long is this study supposed to run?
So we've started it. It's taking place over the summer. Our goal is to have the model in place to be able to use it for 2022 rates.
And what is the cost?
So it's about the total budget is going to run about $300,000.
Well, this is much better than the other Harvard study we did that said people choose the doctor that they are referred to, which was very insightful. I wanted to talk to Dr. Daphne. You talked about the assumptions. You gave us a good example of an assumptions you're starting with to make this not so complicated. Can you give us some other assumptions you're building into the model?
Sure. So one that comes to mind is that we have data on the amounts that state employees are charged for their plans, but we don't have that data on the other enrollees, and yet their existence does influence bargaining. So we'll have to make a simplifying assumption such as we estimate 20%, or if somebody can give us better assumptions for different agencies or areas, we will gladly take it. Another might be if we aren't able to get granular utilization data for Kaiser, what do we observe about these enrollees so that we can try to estimate what their medical spending is in the plan. So it's a little hard at this point to see, but those are the kinds of assumptions.
Great. And then how many years or decades of data are you looking at? Is it a sample of the data? Is it a stratified? It'd have to be a stratified sample if you're using a sample, but curious about that.
Yeah, absolutely. So our data request that we put in asks for data between 2011 and 2019. So we aren't planning to go back further than that. As an academic, I always want more, but I'm also committed to trying to deliver something of value in not 2 years, but soon. And then in terms of the characteristics, it'll be all commercial enrollees, and we're asking for as granular demographic data as we can obtain under the appropriate regulations.
So, and then I have just one other scenario here. So, would you expect that you would be able to find out from the data that, say, a patient was diagnosed with cancer. And so based on that, they decided to stick with their plan, even though it went up, or that they decided to switch to a PPO instead so they have more choices. And I assume you would divide that out by sex and by maybe ethnicity or age. Is that correct?
Bingo. So, I mean, on my list includes select high cost diagnoses if available, meaning we aren't going to obtain all of the claims data for all of your enrollees for that period of time. We'd probably be in this board meeting in 5 years if we were going to try to crunch it from that level. But we have asked for aggregated data that contains that information, and it is exactly as you said. Related to that will be, plan inertia. Okay, so I made us say I go through this whole decision, I've made my plan, and next year, pretty much it has to be a giant premium change before I'm going to go into that possibility of changing my decision. So what we'd like to do is compare the choices of new enrollees with existing enrollees as an estimate of the importance of that inertia, so that we might say, hey, if you introduce a new plan, don't expect anything year 1 or year 2, but we think given the rate of new enrollment and how long it takes people to switch, you might see an effect after.
Okay. And then one final comment, Mr. Jones and Dr. Molds, I have a concern that if we are trying to find out how many of our members would want to switch to a low-cost HMO, my concern is that when I think of low-cost HMOs, I think of plan design changes that would mean less services, less benefits, and poorer health care. And I would certainly not support that based on my knowledge.
So that's an important point, and thank you. One of the very first questions that Dr. Daphne asked us was sort of limitations going in on where we were willing to go and where we weren't willing to go, and we identified high deductible, high cost sharing plans as a place that we did not intend to go. So she has excluded that from the realm of possibilities. We're looking for efficiencies in other places for a bunch of reasons, including the fact that our charges, and talking about this more this afternoon, both to keep our prices as low as possible, but also to make sure that our members are getting all of the health care they need and that they're staying healthy. So.
Yeah, because I could see that we would end up moving people. We have another death spiral if we offered a low-cost HMO, so all our healthy young members go there, and then we're stuck with I call them sicker. You call it something else, but our sickest people going into a plan. Somebody will just purse care. So I'd hate to have us start this process and end there, but it sounds like we're not doing that.
Yeah, and that conversation is also taking place during the risk mitigation discussion this afternoon. So we're focusing on both of those issues.
Thank you. Thank you.
Good question.
Thank you, Mr. Jones.
Okay, thank you. Okay, Ms. Middleton.
All right, thank you, President Jones. Question for, I think, Dr. Daphne, but first I do want to compliment Dawn and the team for putting a program together like this. This is the kind of study that we need. Will this study be contrasting both capitated care plans and fee-for-service plans?
So we don't have plans to try to model out how changes in the provider payment might affect the outcome. So we're going to hold that constant.
I'm not sure I follow.
Oh, how about no?
Okay, so you're not going to be looking at capitated plans.
Well, let me rephrase. There's very complicated, in particular, Marta Green has done a phenomenal job of trying to explain to me and my team all of the components that go into pricing CalPERS, where I understand a number of your plans have capitated provider groups that are part of it. They will all be included. What is not included is that we are mostly modeling how a change in your insurance plans will affect outcomes and not how a change in the way you compensate or those insurers compensate providers might change things. That would be a separate kind of an endeavor.
Yeah. So they won't be differentiated in the analysis, I think is the.
All right. When I hear numbers such as 55% greater cost for a colonoscopy in Sacramento to Orange County, does that apply whether I'm in a capitated program or in a fee-for-service program?
So those are averages. The cost differentials between I do not have them at the tip of my tongue, unfortunately. The cost differentials between our capitated arrangements and fee-for-service arrangements exist. Happy to kind of share some of that data in the future, but yes. The arrangements between the insurers and the providers providing the care will bear on the ultimate cost. But these are averages in an area, irrespective of whether they're capitated or fee-for-service.
Okay. And as Dawn knows from private conversations that we've had, I have concerns about the ability of us ever to get control over the pricing system in a fee-for-service model, and believe that we need to be looking far more seriously at what kind of actions can we take not to change the quality of care that anyone is receiving, but that the incentive under capitated models for providing more preventative care is more strongly evident to the provider, because they participate in the gain when individuals do the things that prevent high-cost healthcare decisions to have to be made. And I apologize, I know that's a comment, but last
It's an important one with which I agree.
All right, thank you. Last question I have is, why is Medicare plans outside the scope of the project?
Don froze it in an opportune moment, but the big picture reason is that scoping out the kind of analysis that was required as against the budget that CalPERS had, it wasn't feasible for the team to do an analysis for Medicare, which just has a whole host of different considerations.
All right, thank you very much. Good luck.
Thank you.
And we still can see Don's initials anyway. Okay. Miss Oliveris.
Thank you. Dawn and Professor Daphne, this is interesting. How do we look at this report and its recommendations being structured? Will there be a type of rating system based upon competitiveness of different markets or insurers? How do you see that looking?
Right. Okay. It depends on what we find. We don't have a structure yet organized, but I could imagine considering like at least two approaches. One might be taking a few different demographics, and they could be based on family, they could be based on health conditions, residents, etc., and saying, here's what this set of recommendations might how it might impact these different groups and where, because I think that equity and is an incredibly important issue that needs some data before you make a decision. You want to be aware of that. The other, besides the representative consumer, is then also to take different approaches. So if we, the complexity of strategy execution is something that one has to consider. So if what came from this is that you need something different in all 58 counties, as a business school faculty member, I would not suggest. I would say you're going to have to pick maybe 3 options and execute one of these 3 and maybe identify the counties. So I imagine we would have something like option 1, heavily recruit a plan of this kind in these areas. Option two, commit to some long-term arrangement that where the payer say agrees to 10% reduction by the end of 5 years in spend per attributed member, etc. So that's what I have in mind, and I really hope there will be data that will clarify what makes most sense.
So yeah, it sounds like optimization scenarios. It sounds interesting. What factors will go into that? Will we be looking at like transparency? And by transparency, I mean in terms of fees, because right now there's so much variation. There is no requirement for providers to disclose their fees. I would love to see that someday. But employee satisfaction, member experience, coverage, and then also, and I know this might not seem related, but it is, investment practices and performance. And I say that because at the end of the day, whether for-profit or nonprofit, insurance companies are only investment firms. The service they provide is healthcare, and they will have some cash on hand to cover claims, but they're investment companies.
So to the extent our ability to incorporate these characteristics is going to depend on what kind of data we can get about them. And we are engaging, CalPERS only has so much historical data and in a systematic way on all of the different health plans that captures some of these things, such as, did the plan have in place a provider transparency tool? As you're aware, many people don't use these tools. I understand you have an engagement with Castlight, and I really hope they get your members to use it. But empirically, that's not so common. On the financial status of the carriers, that's interesting. I don't know how much that affects the member choice unless it indirectly impacts the service.
The cost.
I expect that perhaps through HEDIS, one could get these kinds of data, right? And
I see Department of Insurance, Department of Managed Healthcare. Yeah.
That's a good idea. Thank you.
Thank you.
Yeah.
That's all I had.
Okay, thank you. Mr. Miller?
Yeah, thank you, Dr. Daphne, Dr. Moles. This has been very, very enlightening and encouraging. I think so many of the things have been brought up already that the whole notion that in theory there's no difference between theory and practice, and in practice there is. And you, Dr. Daphne, have mentioned, and others have, that the complexity is where there's just so much complexity. There's so much complexity that we could get wrapped around the axle and study. And by the time you start to get some understanding, things have changed. It's such a dynamic marketplace. Our stakeholders and our constituents are dynamic in terms of their needs, the different segments, the different acuities, the different locations. And so I'm really thinking this is just the kind of thing, one instrument that it may be, that we need to get some fundamental ideas about modeling how people are making choices given our current environment and where things may go, to help us negotiate better, to help us make better choices about the offerings, and word optimize, I think, is the right word, to try to start optimizing.
Mr. Miller, excuse me. Please mute your phone because it's got a lot of traction coming through. Okay, continue on, Mr. Miller.
Okay, and so I'm really encouraged. I'm excited to see the results and how they're presented, because there's so many things that go into the decisions our members make. And so that's where my question comes, is ultimately, do you think we'll be able to use this information to then focus on what else we need to study and learn, but to be able to help our members optimize their decision making? Because as Ramon pointed out, I see lots of decision making that's based on aggressive marketing by healthcare organizations, where members' perceptions of the value proposition presented to them are not necessarily congruent with real clinical quality outcomes or even patient experience outcomes. And often they're not looking at HEDIS data, they're not looking at, they're making decisions that are often suboptimal for them. And as a result, they end up having to try to like change or wait till the next enrollment to change, or only when they actually have real needs that bring to mind that, oh, I'm not in the best plan for myself, or my needs have changed. And ultimately, maybe there's a more active role for CalPERS in helping direct members and helping them make those decisions once we understand everything a little better.
So Don, I heard two. I heard two distinct questions. I suspect both are for you. One is with regard to the usefulness of a study that, of necessity, is going to simplify from the complexities of the real world. And I think you're very well suited to answer that, given your history in studies and grants, et cetera. And then the second concerns choice architecture and optimizing that, which I expect you have thoughts on it. I'm glad.
I do. I think there was a point embedded in there too, which is a very good one, and that is that people aren't always purely informed, rational choosers. You know, and the role of advertising, et cetera, can complicate results. Which actually, not to turn it back to you, but I'll let you tackle that one. It's a great question, but one you deal with every day. So part of the reason that we engaged Dr. Daphne is that, in addition to being a fantastic academic, she's notoriously practical. And so from the get-go, we have talked about this study as culminating in a very usable tool, something that we can that we can use for practical effect. And so we started with the outcomes when we talked about what we wanted to look like, and so we have an eye towards that. You're quite right that that data will change over time, and that this will be something that we'll need to, if it proves as useful as I'm hoping it will be something that we'll need to update periodically with new data, et cetera, and probably tweak after we've used it. But that would all happen because it's proved useful in both our negotiations with health plans and our decisions about where we try to encourage new networks. So that's I guess the kind of a larger answer to both questions.
Great, thank you both, and to the whole team.
Okay, thank you. Ms. Green Ross?
So my question is about, mostly to Don, but Professor Daphne as well, because she mentioned it, and you suggested at the end of your written material that one of the tools would be obviously more litigation, like the Sutter lawsuit, and I know it was a settlement. So it probably is a little unclear about what, because lawsuits take forever, legislation can be more timely and more effective, because if you use litigation as a tool, it's not going to help anytime certain. But I just wondered if you could explain a little bit about what we have learned from the settlement, because it didn't, obviously if it's settled, we didn't get to, the AG didn't get to necessarily establish details and gaps in the law that we might need, that could be more directly targeted to help some of the risks of competition on prices.
Sure. I'm gonna say just a few things and then turn it over to Dr. Daphne, because she has done so much work in this space as an expert witness in a lot of these. But I'll just kind of share how CalPERS has engaged in some of these. So, you know, there have been a combination of lawsuits, so the Sutter lawsuit being the most significant in California over anti-competitive practices. And then the other area where the Attorney General is active is in the review of potential mergers. And so we have participated as experts in all of these areas. So before my time, Kathy Donison was a frequent expert in the Sutter litigation. And since Marta and I have been here, both of us have been experts, not in lawsuits, but in attorney general reviews of mergers. And what we do there, what the questions are typically to us are questions about, how it's likely to affect CalPERS members, their access to care, our prices, and we rely on our data to serve that role. We see it as a critical role, both because the outcome of those decisions affects us, but also because we are participating in a broader canvas and think it's important to make those contributions. So that is, as we do more of that, we are, more frequently contacted by the Attorney General and others just to get informal thoughts about ways in which various mergers or other actions could affect the market. We are, I think, and if Matt's on, he can confirm this, but I think we're somewhere between 11 and 13% of the Sutter settlement, so not insignificant. And so it's a natural that the Attorney General and the FTC, we've done it there as well, will come to us for our input in these cases.
I don't know how we are on time, so somebody give me a range between 1 and 4 minutes that you have for me to respond.
Why don't you split it in half and go 2?
All right, I will do it. Thank you for the question, an area near and dear to my heart. So you queried CalPERS regarding their engagement in lawsuits to try to offset some of the exercise of market power. I don't know anything about CalPERS litigation strategy. Even if one exists beyond active engagement, I would just commend them and say that the role that any large employer, large purchaser of health benefits plays is critical to all of the enforcement efforts. It is costly, it takes time, and it has benefits that exceed those beyond the membership, but I think it's got to be a prong of it. In terms of what to do, litigation is so slow, and the settlement that the AG came to prohibits some of the contractual practices that are believed to have led to much higher prices. For example, all or nothing contracting. If you want any Sutter hospital, you have to take them all and at our rates and without steering away from them. So those practices are going to be prohibited going forward. So if that really, upon renegotiation, happens as it's meant to, we ought to see a real tempering of prices. Of course, actual price declines are pretty rare. So you're already really high spending. So even if you stop the growth, you still have a problem. Brings me to the second question, although I could talk for longer about anti-competitive practices, which is what disciplines prices outside options. So I'm on the benefits committee here at Harvard University, and we take a look at our spending and engage with our carriers. And one of the big ways for us to try to reduce spend, frankly, is to change the site of care where people are receiving their imaging, their infusions. It's extraordinary, the difference. Really want to cut the spending, and I know that CalPERS has some separate initiative on it. You think if colonoscopies are 55% more when they're performed in an affiliated hospital clinic, got to find some upstart that you maybe even fund or you commit to and say, we're going to just say that's our default place and you have to have an exception note. I'm just riffing, and probably there could be plenty of reasons not to do that, but it's disciplining the market through strong action because litigation is very slow for that.
Ms. Green-Ross?
Yeah, that was why I was asking about that and wanting to know what the impacts were. So that's really helpful, and I appreciate that. I know it's very timely, and I like the riffing on funding an upstart. For the private equity staff listening. Okay, thank you.
Okay. Ms. Taylor.
Yes, thank you. I kept typing in the wrong place there to get a question in. First of all, thank you very much, Don, Dr. Daphne, for putting this together. I'm excited to see the results of this. I guess I think I kind of wanted to go back to, I think it was Ms. Middleton, who was talking about making sure that we didn't go to low-cost plans. And I already see the trend. I mean, I get what our goals are, but I just want to make sure that while, you know, we're taking into account how our members are choosing their plans, et cetera, that we're not trying to force them into narrow networks either, because not necessarily is that the best option. So, you know, we've got a couple of plans that are starting to have some really narrow networks, which were supposed to have been, when I first started with the state, I think, I can't remember the name of it, Access Plus, was that our low-cost, narrow network Blue Shield plan, which ended up not being the case. I'm concerned because then we get wrapped up in these supposed narrow networks, and the next thing we know, they become high price. So,
Yeah.
What are your thoughts on that? Because I don't know how Trio is doing, but I just wondered.
Yeah, sure. A couple of thoughts. One is that, you know, so on lower price in general, as I've said, our goal is to engage high quality, low price providers where possible, and to divert care to lower cost settings. So as Dr. Daphne pointed out, that, you know, the strategy with Harvard apparently is a strategy that we're trying to put in place in Santa Barbara and Monterey, where we're working with Shield to develop a network that will be providing services for anything you can do outside of the single hospital in the area in that setting. There is no connection. There is little connection between quality of care and price, and in some instances, there's an inverse relation between quality and price. But the key in all of these cases is to make sure that the folks that we're contracting with on the provider side are high quality providers. As for narrow networks, you know, a couple of things. One is, you know, we are fortunate in California to have very strong network requirements. Our goal is not to decrease access in CalPERS. Again, it's to engage high quality, lower cost providers to create competition. So, you know, we're going to be mindful of that with anything that we develop. And as I've said, the notion of going to high deductible plans is not on the table at the moment. It's not part of the analysis.
Great. So, and I will say, look, when I'm sitting at my desk at work and people are coming up saying, oh my God, my healthcare went up. Where can I go? What plan can I go to that's cheaper? It has been my experience personally with our members that they don't stick with a specific doctor's group or whatever. Sometimes they do, but you know, whatever is cheapest for them. The main thing is that healthcare impacts our paychecks is what the problem everyone has brought to me. But also, I think one of the things that in one of our July offsites, maybe a year or two ago, that really hit me between the eyes is it seems like it's not very efficient. That we do the things we're supposed to do. CalPERS is innovative. They have always done some really amazing things to get prices under control. And then the next thing we know, our healthcare providers or our insurance carriers have found a way around that and continue to charge high prices. So, for example, reference pricing, or, declining use of ER and urgent care. We've done all of that. And here we are still struggling. And I've only been on the board 5 years, but I remember 15 years ago having a town hall with my union and insurance providers, because that's when they were charging 15 to 20% increases. So,
Yeah.
and everything we've done since I've been on the board and since before that has supposed to been contributing to reduction of prices. So forgive me if I sound a little desolate here.
It is both a good point and a fair point. This is a game of sort of perpetual whack-a-mole, or it feels that way. But when you're playing whack-a-mole, you need to stay on your toes and you need to be adaptive. And so you just kind of you stay in and you keep making the adjustments to address this. Dr. Daphne has made a career of this, so she will probably have lots to add too. So.
I mean, whack-a-mole is a frustrating game to play. I have to correct the record and say, while we should do something about site of care here at Harvard, we aren't, okay? Our carriers aren't really helping us, and it's terrible. So I don't want to claim that we've possibly solved that, but there is an onus on purchasers to do more, and I would say that the providers try to foil us at every step. So I was at my provider. I was ordered, hopefully this doesn't make anyone uncomfortable, I need a mammogram, okay? And I said, okay, great. They wanted to schedule me at the front desk for one at Brigham and Women's Hospital affiliated with Harvard Hospitals. I said, I'd like to go somewhere else. And can you give me, the script? They said, no, you're going to have to call some special number and get them to fax it to you. Something ridiculous like that. So one option is just you schedule it for me. The other option is I'm not really sure, go deal with it. So they're going to make it very hard for us to contain our costs. Mammograms are free anyway, right? So what's my incentive to do this? I'm trying to basically agree with you and also not to overpromise. I don't want to overpromise with our study. We're going to try to get some ideas on what might maximize value given the kinds of carriers you have and the choices people are making, and what you might want to work on your own or potentially with other employers to try to introduce in a given area. But I can't make the mousetrap better myself.
It is just very frustrating, and as we all want affordable quality health care, all my members do that we represent, all the people we represent want affordable quality health care, but the constant is in this is that no matter what we do, we have not been able to contain prices. And I will say that providers and insurance carriers are very nimble. They're really good at figuring out a way around whatever it is that we've done to bring prices down, utilization, whatever. Because then they just, if they're not making the profit, or whatever it is that they need to be making, because we cut ER visits and utilization, then they're charging more for something else. So I hope this study helped us. I look forward to this study. So thank you very much.
Okay. Okay, Mr. Rubalcaba, is that a question or a comment?
I don't have, I'm done.
Okay, thank you.
Thank you.
Okay, thank you. Okay, so we do have a request to speak from the public. Mr. Fox, I understand you have 2 in the queue, but to the public who may wish to make public comments, you could please call into the meeting at this time so that you can be, information can be given to the screeners. So with that, Mr. Fox.
Thank you, Mr. President. We have Larry Woodson, California State Retirees.
Okay, good afternoon. Larry Woodson again, California State Retirees. Thanks for the opportunity to comment. I had a number of things I wanted to say about the Southern Health settlement and questions, and many of those have been answered. I appreciate Dr. Daphne's bringing it up, and then the board members. So I think what I learned is it sounded like CalPERS actually can benefit from that settlement to the tune of 11% of the $575 million settlement. And they're not a plaintiff, so that's surprising, and that's good news if I understood it right. I do have a question about the settlement does say it limits what they can charge for a patient out-of-network services, and that's supposed to prevent people from facing surprise medical bills. And my question is, will that apply to members on the PPO plans that get surprise medical bills, and the current state law does not cover PPOs? And then I want to raise something that I don't know if it can be a part of this study or not, but there have been two articles in recently, one in Bloomberg titled "How Private Equity is Running American Healthcare," and one titled "Private Equity Firms Now Control Many Hospitals, ERs, and Nursing Homes." That's in NBCnews.com. And I would add doctors' practices, surgical centers, urgent care centers, and it's a little alarming because the names are those that are very familiar to us: Blackstone, Apollo, Carlyle, KKR. They've spent over $340 billion in the last 10 years purchasing provider and healthcare-related services. And of course, one of their models is to buy a company, drastically cut costs, and then sell for a profit 3 to 5 years later. And so my concern is that this, of course, they're not interested particularly in quality of service or and they're negatively impacting our costs. Is that something that can be included in this study or addressed somehow, or maybe through a different effort? And I would just close by saying that it's, I'm going to look into it more in terms of CalPERS specific investments, but if the investment group's investing in these kind of purchases and it's impacting costs on the other side of the house, it's sort of like robbing Peter to pay Paul. So I'll leave it at that. And I know the questions I asked, you don't have to answer and comment, but if staff has any answers or if any board members think there's a worthy question there that they want to follow up on, I'd appreciate it. Thank you.
Okay. Now, I would just ask Mr. Moles as we move forward with the project is to take those comments under consideration as you move forward. Next person, Mr. Fox.
Yes, Mr. President, we have from the Retired Public Employees Association, Joanne Hollander.
Good afternoon. This is Joanne Hollander from RPEA. Thank you for having me. Can you hear me?
Yes, we can.
Okay, good. My video doesn't match the audio, so I'm a little behind on the video. Yes, thank you for listening, and I appreciate all the work that the board and the staff does. I know it's a lot of work. I had just a few comments and a couple questions. On the telemedicine, I know many of you, and I know myself, I've had several Zoom and teleconferences with doctors, and I really do think this is a way to go in not just rural areas and mental health. I think there are a lot of people that take maintenance medications that really don't need to go in every time to see the physician. They can do it over the phone. Maybe some of the preventative medicine issues that come up that can be discussed on the phone. You don't actually need to have a lot of, or you're being sent for tests somewhere else anyway. So I think this is something to expand on. I know even after the COVID's over, I'm sure people don't really want to spend a lot of time sitting in waiting rooms anymore. I know I don't. I really prefer not to. So I think this is something that we should promote with time. Then I wanted to mention, I know that Kathleen Donison used to say, okay, go to your physician first. Then there was a big push to have people go to urgent care centers instead, go to the clinic instead. Then recently, just before she left, is like, go back to the doctors, go back to the primary care doctors, don't go to the clinics. So I was wondering if this is going to play into your study, because things shift from PERS's perspective to the patients, to the members, and it gets confusing. I mean, I've watched this over many, many years. I've also seen the number of providers expand and contract. I was in this over 30 years. So, it's just kind of like, I agree with Trish Taylor. It's a moving target. And I don't know if we ever were going to reach any of the goals attempted, but you've got to try. I understand that. And then the other question I have is, are the PPO basic plans going to be evaluated in this study of basic plans? Because they're really CalPERS plans. There's really no competition other than people move in and out of the PPOs to other plans that are outside providers. So I wasn't sure how that works exactly. And that's just but overall, I think you folks are doing a great job. Keep at it. And please keep the stakeholders in mind in your decisions. Thank you.
Okay, thank you very much. Okay, well, seeing no additional requests to speak from the public, it brings us to, I think, about lunchtime. So we want to thank Mr. Moles and Dr. Daphne for a very informative presentation, and thank you very much.